Hello, I'm Dr. Sumi, one of the mentors at StudyMEDIC, and here we are with you with the Flash Revision YouTube series. We will be covering the module of Urogynaecology. The topics that we are going to discuss today are pelvic organ prolapse, urodynamic images, and the bladder pain syndrome. Now, let's get started with the extended match questions. So this is our first question. We have the options from A to K, and this is a clinical scenario. So here we have a 65-year-old sexually active woman who presents with symptoms of vaginal bulge and discomfort. She underwent a hysterectomy 5 years ago. Examination confirms wall prolapse. Now, was the most appropriate surgical intervention in her case? So the thing is, we have to read the question properly. Okay, these are the options. We have options running from A to K. Now, the correct answer is laparoscopic sacrocolpopexy. Laparoscopic sacrocolpopexy is considered to be the gold standard for managing post-hysterectomy wall prolapse. It provides excellent support by attaching the vaginal wall to the sacrum using mesh with minimal impact on sexual function. Now, this is a very one of the very favorite questions. Okay, this is something, this concept should be very clear. Now, these lines are picked up from the Green Top guidelines and should be well versed with these lines. Women should be aware that both abdominal sacrocolpopexy and sacrospinous fixation, these are effective treatments for primary post-hysterectomy wall prolapse. Now, if you're talking about abdominal sacrocolpopexy, it's associated with significantly lower rates of recurrence, lower rates of dyspareunia and postoperative SUI. But this doesn't mean that it reflects on the lower reoperation rates or higher patient satisfaction rates. Now, if you compare it with sacrospinous fixation is associated with earlier recovery, but it may not be appropriate in women with short vaginal length and women who are sexually active, women who have any issues with intercourse with pre-existing dyspareunia. Sacrospinous fixation is not what you're going to opt for. Now, what is the technique that you'll employ at the time of vaginal hysterectomy to prevent subsequent post-hysterectomy wall prolapse? That is MEDIC-MRCOG-EBCOG-MRCPI-FCPS-OBG-IBCLC. Again, a favorite exam question. Also, suturing the cardinal and uterosacral ligaments to the vaginal wall at the time of hysterectomy is effective in preventing wall prolapse following both abdominal and vaginal hysterectomies. Also, when at the time of vaginal hysterectomy, if we feel that the wall is descending to the introitus, then you have to use a technique of sacrospinous fixation. Again, a favorite exam question. Okay, now let's move on to the clinical scenario 2. We have a 60-year-old woman who presents with stage 2 pelvic organ prolapse and she complains of vaginal dryness and mild discomfort during intercourse. Now here, what's the most appropriate initial management? Okay, they are asking about the initial management. You have to read each and every line of the question. Okay, they are not asking about the final management. They're asking about the initial management. So what you should think is initial management, basically it involves around it revolves around lifestyle modification and things like that. So now here we have, these are the following options. And the correct answer is pelvic floor muscle training with vaginal estrogen. Okay, now for early stage prolapse and symptomatic vaginal atrophy, conservative management with pelvic floor muscle training to strengthen the pelvic muscles and vaginal estrogen to address atrophic symptoms is appropriate. Now, whenever we are talking about pelvic floor muscle training, you should remember the thing that we ask the patient to squeeze the pelvic muscles. We ask them to squeeze the pelvic muscles 8 times in a row. And like that, you have to do it 3 times in a day. And for prolapse, you have to do it for 4 months. So 8 into 3 into 4 for prolapse. Now, if it's for SUI, you have to do it for 3 months. Okay, you should remember these values. Okay, now pelvic floor muscle training is an effective treatment option for women with stage 1 to 2 vaginal prolapse. Okay, it's for stage 1 to 2. And vaginal pessaries are an alternative treatment option for women with stage 2 to 4. Okay, these are things that you should remember. Now, in third scenario, we have a 72-year-old frail woman with stage 3 prolapse. She is not sexually active and she wants a definitive solution. So here, what would be the most appropriate intervention? Now, here we are dealing with a 72-year-old elderly woman who wants a definitive management. Okay, so here the answer would be colpoclysis. It's definitive, it's minimally invasive, and it's suitable for women who are not sexually active, and frail women. Okay, basically it involves obliteration of the vaginal gland. Now we have a 45-year-old woman with stress urinary incontinence who is found to have a moderate cystocele on examination. Now, what investigation should be performed before planning surgical intervention? Now, what we should remember is if it's a clear-cut case of stress urinary incontinence and if you're planning on surgery, usually further tests and all are not needed. Okay. Now, these are the options. Now, the answer here is urodynamic study. Now, what we should remember is for a clear-cut case of stress urinary incontinence, before embarking on surgery, urodynamic studies are not indicated, but in certain conditions, like this is from the TOG article, but if this is suggestion of voiding dysfunction, anterior compartment prolapse, or previous surgical management, previous failed surgical management, then you have to do urodynamic investigations. Everyone, please go through this table. It's important. For urge incontinence, before surgery, we always do urodynamics. For SUI in these conditions. Okay. Now we have a 65-year-old patient who presents with complaints of frequent urination and urgency. Urodynamic studies reveal a first sensation at 90 ml, bladder capacity of 200 ml, post-void residual urine less than 50 ml, and detrusor pressure rising to 30 centimeters of water during filling. Now, what's the most appropriate diagnosis? See here, just by looking at this, we can reach the diagnosis, because one thing that we all should know is during filling phase, detrusor pressure should not rise. If there's rise of detrusor pressure during filling phase, definitely there is detrusor overactivity. Okay, so that is one thing that you should remember. And then also we should know the values. Okay, we'll be discussing it later on. Now here, these are the options, and this is a urodynamic image. So whenever we are seeing a urodynamic image, we have to see that first, this is a filling phase and this is a voiding phase. And in filling phase, basically we have to concentrate on these three pressures: P vesical, which is the bladder pressure, then P abdominal, which is abdominal pressure, and the P detrusor, which is the detrusor pressure. Now, normally during the filling phase, detrusor muscle should be quiescent. There should not be any rise in the detrusor pressure. If you see rises, peaks of detrusor pressure in the filling phase, we can know for sure, we can say it for sure that it's a case of detrusor overactivity. And if this is associated with leakage of urine, they show urine leakage as, flow plus like that they'll show. Okay, then it becomes a case of urgency incontinence. Likewise, now see here we can see that in the filling phase, the P abdominal pressure is also rising. Okay, we see that the P abdominal is rising. Now the abdominal pressure rises if there's any coughing, laughing, any Valsalva being performed. And abdominal pressure, the rise of abdominal pressure would always be reflected by rising in the vesical pressure. Now, if this associated leakage, then it becomes a case of urodynamic stress incontinence. Now, this is a basic principle behind urodynamics. Okay. So now in our case, we saw that the detrusor pressure is rising during the filling phase. So this is a case of detrusor overactivity, because detrusor overactivity is characterized by involuntary contractions during the filling phase, which leads to reduced bladder capacity and urgency. Okay. Now, this is in brief about urodynamics. It includes all measurements that assess the function and dysfunction of the lower urinary tract by any appropriate method, including cystometry and the pressure flow studies. Okay, the basic requirements are you have to do the uroflowmetry, then we have to check the post-void residual, then the cystometry and the pressure flow studies. Okay, so this is a basic normal cystogram at the when we are starting, before starting cystogram, first what we do is a uroflowmetry. Okay, uroflowmetry, we basically ask the patient to void, and we measure the volume that is being voided, the flow at which it's being voided, and after the patient is voided, patient usually voids it to an automated commode wherein all these values can be tested. And after the patient is voided, we check for the residual urine. The residual urine can be checked by either inserting a sterile catheter or by using ultrasound. And after that starts the normal cystogram, and After that starts a cystogram, wherein you put in a pressure catheter inside the bladder, which gives us the value of the vesical pressure. And then to check the abdominal pressure, we insert the catheter inside the rectum. Okay. And then how do we reach the detrusor pressure? Detrusor pressure we reach by subtracting the abdominal pressure from the vesical pressure. Now, this is a lot of theory. Please read the talk article properly. Okay. Then after during cystometry, we instill the bladder with saline, and then afterwards we check for the rise of the pressure. We check all the pressures. We check the. Then afterwards, again the patient is asked to void. And then here we look at the pressure flow studies. Okay. Now, this is a graph of the uroflowmetry. This is a normal graph. It's like a typical bell-shaped curve. Here we check the Q max. Then this would be the average Q max and the volume voided. For you to make any interpretation of uroflowmetry, at least 100 ml of urine should have been passed. Okay. Now, as we discussed before, this is a normal shape of a uroflowmetry. Now, there are conditions wherein if there are several peaks in Q max, okay, there are several peaks. It could be caused by bladder outflow obstruction, unsustained detrusor contraction. If the Qmax is reduced, it's urethral stricture, external urethral compression. And if it's very high Qmax, it's possible detrusor overactivity. Okay. Now, here we have another patient, a 60-year-old who comes with complaints of urgency, frequency, leakage upon coughing. Okay, and urodynamic shows an increase in P abdominal pressure, P detrusal pressure, and vesical pressure also associated with leakage of urine. Now, what's the most likely diagnosis? So, here we have leakage upon coughing. Leakage upon coughing is stress urinary incontinence, and there's a rise in detrusor pressure also. So both the things are there. So it becomes a case of mixed urinary incontinence. Okay, it's mixed urinary incontinence because there are both the things. Now here we have a 70-year-old woman who complains of difficulty in voiding, and there's a sensation of incomplete bladder emptying. And urodynamic studies are showing high detrusor pressure during voiding, decreased flow rates, and increased post-void residual urine. So here it's suggesting bladder outlet obstruction. So if there's any obstruction, the bladder would try to, the detrusor muscle would try to, it would try to squeeze more. So it would be high detrusor pressures, but the flow rate would be less, and there would be more of post-void residual urine. Okay. Now, moving on to another question. 68-year-old woman presents with difficulty in voiding, sensation of incomplete emptying, and occasional incontinence. There's a large post-void residual urine and reduced detrusor pressure during voiding. Okay, now during voiding, if detrusor pressure is less, that means detrusor muscle is not working properly. And there's a bladder capacity is 500 ml. Okay, and a large post-void residual urine is also there. So this is a case of hypotonic detrusor activity. Okay, so detrusor underactivity. So it's reduced detrusor pressure during voiding. So there is ineffective bladder emptying. There's a large post-void residual urine. Okay. Now let's move on to another different topic, which is bladder pain syndrome. Now the options for treatment of bladder pain syndrome are all except. There are multiple options that are given: intravesical lidocaine, intravesical hyaluronic acid, intravesical injection of botulinum A, intravesical heparin, oral pentosan polysulfate, intravesical chondroitin sulfate, intravesical DMSO, cystoscopic fulguration of ulnar ulcers, neuromodulation, and oral cyclosporin A. Now, these are all the treatment options except, what's the correct answer? Except oral pentosan polysulfate. Okay, oral pentosan polysulfate is not indicated. Now, which of the following about bladder pain syndrome is not true? See, the thing is, you have to read the question properly. Okay. Sometimes, if you're not careful, we might miss this not before the true. So, and our answer becomes wrong. Okay. So here the options are: bladder diary is completed at the initial assessment. Now that's always the case. Detailed medical history, physical examination should be performed. Food diary has to be used. Urine should be tested to rule out UTI. Investigations for urinary ureaplasma and chlamydia can be considered in asymptomatic women with sterile pyuria negative cultures. Now this is not true, because why would you take asymptomatic women, right? Then urine cytology should be tested for women with suspicion of malignancy. It's a diagnosis of exclusion. Bladder biopsies are not recommended. Hydrodistension is not recommended. Cystoscopy is required to exclude other conditions. Okay, so the answer is E. Testing for urinary ureaplasma chlamydia is indicated in symptomatic women, never in asymptomatic. Now, the National Institutes of Health developed diagnostic criteria for bladder pain syndrome with the following inclusions except. These are all the inclusions except one thing. There definitely is pain associated with bladder filling, and there's urinary frequency, glomerulations on cystoscopy. Classic Hunter lesions are seen on hydrodistensions. These are not absolute things, but can be seen. When the Hunter lesions are seen, it becomes a case of interstitial cystitis. Okay. Hydrodistension under anesthesia to 80 to 100 centimeter water under pressure for 1 to 2 minutes. The glomerulation should be diffuse. Glomerulation should be present in at least 3 quadrants of the bladder at a rate of at least 10 per quadrant. Glomerulation should be along the path of the cystoscope. Hana lesion may be seen as inflamed fibril areas. Now, here the wrong answer is that the glomerulation should be along the path of cystoscope. That's not the case. Glomerulation should not be along the path of the cystoscope. Okay. Now, these are the options. 35-year-old woman is newly diagnosed with bladder pain syndrome. Symptoms are moderate, no Hunter lesions. What would be the initial management? See, as I discussed before, whenever we are talking about initial management almost always revolves around behavioral therapy and lifestyle modification. Okay. So option D is behavioral therapy and lifestyle modification. Okay. Now we have a different question. Coughing during filling phase produces simultaneous rises in vesical abdominal pressures with no change in detrusor pressure. Urine leakage occurs. Now there is coughing means there's a rise in abdominal pressure that would be there. That is transferred to the vesical pressure, and there's urine leakage. That's a case of urodynamic stress incontinence. Now here there can be a confusion between stress incontinence, urodynamic stress incontinence. We call it stress incontinence when it's a symptom. When the patient says that she's coughing and she's leaking urine, it's stress incontinence. But when you're picking it up on the urodynamic studies, then you call it urodynamic stress incontinence. Okay. Now, a 70-year-old woman with uterine prolapse, she's frail, she prefers non-surgical management. Okay, and she wants symptom relief. Now, whenever we are talking about non-surgical management, it's always about vaginal pessaries, non-surgical. Okay. Now, what's the safest treatment option for women with bladder pain syndrome during pregnancy? This again is an important topic. Now, for bladder pain syndrome during pregnancy, the safest treatment option is this: oral amitriptyline and intravesical heparin. Now, out of oral amitriptyline and intravesical heparin, oral amitriptyline would be the safest because it's oral. Okay. But if both the options are given, then you should go for both if both are there, then both options would be safest. Okay, both oral amitriptyline and intravesical heparin. Now we'll move on to the single best answers. 70-year-old woman presents with long-standing history of recurrent UTI. Despite the symptoms, multiple urine cultures have been negative. Cystoscopy reveals numerous areas of hemorrhage throughout the bladder. What's the most likely diagnosis? Simple question, right? It's bladder pain syndrome. Actually, it's not bladder pain syndrome. It's interstitial cystitis. Why? Because here the cystoscopy is showing numerous areas of hemorrhage. So if we have any cystoscopy findings, if we have any biopsy findings of, that is indicating if there are biopsy findings and cystoscopy findings, then it's a case of interstitial cystitis. Purely if it's based on symptoms alone, then it is bladder pain syndrome. Okay, this is what you should be careful about. Interstitial cystitis, now often referred to as bladder pain syndrome, but it's characterized by interstitial cystitis. It's characterized by chronic bladder pain and findings such as glomerulations, petechial hemorrhages on cystoscopy. Okay. Now, whenever there are cystoscopic findings, then you have to mark cystoscopic findings or biopsy findings, and you have to mark interstitial cystitis as the correct answer. A 65-year-old woman presents with a long-standing history of recurrent urinary tract infection. Urine cultures have been uh, negative on 3 separate occasions. The most appropriate investigation would be cystoscopy. Okay. In case of recurrent urinary symptoms with negative cultures, cystoscopy is the most appropriate step. It allows for direct visualization of the bladder lining to identify any abnormalities such as interstitial cystitis, tumors, bladder stones, which may not be detectable through other non-invasive tests like urine culture. Now, a woman is scheduled for vaginal hysterectomy. She has no history of bladder bowel dysfunction, but she's concerned about the possibility of vaginal wall prolapse. So, you are discussing about preventive techniques that can be used to reduce the risk of vaginal wall prolapse, which is most effective at reducing the risk of intraocular and vaginal wall prolapse. So, as we all know, it is called caldoplasty. Okay. Now, a 52-year-old woman who underwent pelvic organ prolapse surgery with mesh placement 18 months back. She is presented with symptoms of mesh erosion. To whom should the mesh erosion incident be reported? Mesh erosion, it always has to be reported to MHRA. Okay. The Medicines and Healthcare Products Regulatory Agency. Now identify the correct equation. This is what I had told you during our discussion about urodynamic studies as well. So what is the correct answer? Correct option? Correct option is V minus A is equal to D. Okay, so this is the correct answer. V minus A is equal to D. Bladder pressure vesicle minus pressure abdominal is pressure detrusor. Okay, pressure vesicle minus pressure abdominal is detrusor, and the P detrusor normal value is 5 to 15 centimeters of water, and the detrusor pressure should never rise during the filling phase. Okay, now here we are going to show you a grid and you have to identify the stage of the prolapse. Okay, now this 3 by 3 grid, it's very important. So here this point is AA. AA ideally should have been -3. So AA here is 0. And AP is also 0. Okay. AA, this is, AA and this is BA. Okay, AA, BA is 0 and C is -5. Then these are rest of the point. Genital height is the perineal body, the total vaginal length. Then this is the AP, BP. Okay, and the total vaginal length. So here we can see that AA and BA are at 0. So that means it is stage 2. Okay. So AA ideally should be -3. Okay. And AP should also be at -3. But here we have AA and BA at 0. So when it's 0 is the leading edges, the stage 2 is when the leading edge is more than or equal to -1, but less than or equal to +1. That is when the leading edge of the prolapse is within 1 centimeter from the reference point, then it is stage 2. Okay. So all these points, AA, BA, C, where is AA, where is BA, what all, when do you call it stage 0, 1, 2, 3? All these things are very important. You must know it. Okay. Now here, a 45-year-old woman is referred to the urodynamics unit for evaluation of a long-standing urinary urgency frequency. She undergoes cystometry as part of urodynamic studies. There are certain measurements that have been noted. Which of the following is a normal cystometric findings? Okay. So here the correct answer is residual volume of 50 ml. Normal residual volume is 0 to 50 ml. You should be thorough with these values. Bladder capacity normal is 400 to 600 ml. The first urge to void is usually around 150 to 200 ml. Okay. And yeah, the first urge to void is usually around 150 to 200. So residual volume 50 ml is the correct answer. Now here we have a patient who is undergoing vaginal hysterectomy with an anterior wall prolapse. You're about to proceed with VH after exposing the bladder. Which ligament is, after dissecting the bladder off, which ligament would you be clamping? Always you'd be clamping the uterosacral ligament. Okay. So during vaginal hysterectomy, after mobilizing and after dissecting of the bladder, the first step is uterosacral ligament. Now, incidence of women affected by pelvic organ prolapse, that is around 1 in 9. And the incidence of women affected by stress urinary incontinence, that's around 1 in 3. And in the UK, the lifetime risk for Paris women to undergo at least one surgical treatment for either SUI or POP has been shown to be 1 in 10. Okay. Now, a lady with organ prolapse is to have propylene mesh. What type of mesh is that? That is synthetic non-absorbable. Okay, synthetic non-absorbable. Hallmark of bladder pain syndrome is suprapubic pain related to bladder filling. See, all these things are features of bladder pain. Okay, she might have hematuria, she can have nocturia, she can have stress urinary incontinence, dysuria, but the typical feature is suprapubic pain related to bladder filling and the pain that is relieved by voiding. Okay, pain that worsens with filling and improves after voiding, that is characteristic of bladder pain syndrome. Now, recommended first-line management of bladder syndrome, whenever they talk of the first-line management, the initial management, it's always around lifestyle and behavioral modification. Okay. So diet changes, stress reduction, bladder training. Now this table is very important. Okay. So initial history, assessment, first line is always conservative. Painkillers, stress, relief, dietary modification, exercise, physical therapy, support group. Second line, we have oral amitriptyline and cimetidine. Okay, oral triptyline is more preferred. Second line fails, then you have to refer to MDT, pain team, plus or minus clinical psychologist. Third line is intravesical DMSO, heparin, botulinum toxin, lidocaine, chondroitin sulfate, hyaluronic acid. Fourth line is neuromodulation, oral cyclosporin A. Fifth line is cystoscopy, hydrodistension. If anal lesions are noted, it has to be fulgurated. Okay. Now, pelvic floor muscle training is indicated in stage of prolapse. We've discussed it before also. It's either stage 1 or stage 2. Okay, till stage 1 and stage 2, you can offer pelvic floor muscle training. And vaginal pessary is stage 2 to 4. Now, which of the statements is not true? Now, again, this also is an important concept. Colposuspension at the time of abdominal sacrocolpopexy is an effective treatment for SUI. See, abdominal sacrocolpopexy is what we use for wall prolapse, right? So, abdominal, now, if you have a patient with wall prolapse, and she has occult stress urinary incontinence. That means in her, the stress urinary incontinence, it's not a manifest. She is not symptomatic. It's an occult case. Then if you do colposuspension, Bursch colposuspension, which is the ideal treatment for stress urinary incontinence. So for a patient with wall prolapse and occult stress urinary incontinence, if you do colposuspension at the time of abdominal sacrocolpopexy, it is effective. But if the patient already has stress urinary incontinence, if the patient is symptomatic, then colposuspension is not effective. Okay. Then if you're doing a colposuspension at the time of abdominal sacrocolpopexy, it's not effective. Now, this is a true statement that concomitant mid-urethral sling surgery may be considered when vaginal surgical approaches are used for treatment of oocystectomy wall prolapse. Management of recurrent wall prolapse should be through a specialist MDT. Colposuspension performed at the time of sacrocolpopexy, it's an effective measure to reduce post-operative symptomatic SUI in previously continent women. Okay, if the woman is continent, if the patient doesn't have obvious SUI, then if you're doing colposuspension, then it will prevent SUI. Okay, it reduces the symptomatic SUI. And all complications related to use of devices and mesh should be reported to MHRA. So the false statement is that colposuspension at the time of, this is the false statement, that colposuspension at the time of abdominal sacrocolpopexy is effective treatment for SUI. It's not effective treatment. Okay, it's not indicated. Okay, so all the best, everyone. Do your best, study well, read the questions properly, think properly, and then mark your answers. All the best.